Hi everyone, my name is Katrina. I am a professional counseling student and my program is called Olivia's Lighthouse and it is a program in support of postpartum depression. I wanted to give a little overview of the name of my program. I have a personal history of postpartum depression, and this was really a catalyst in my life that led to a lot of changes, and one of those was to eventually go back to school to become a counselor. Certainly, it's a much longer story than that, but this topic is a passion of mine, and I think that's because I felt like my recovery was slower and more challenging than it necessarily had to be. And I felt like this was largely because I did not have access to the proper treatment or proper mental health support early on. I consider myself and my daughter to be survivors of this, and I believe that even in her infancy, my daughter was undoubtedly affected by my own struggles with postpartum depression. And so I just wanted to honor her in this way. And as she gets older, I look forward to kind of talking to her about it more and explaining why I chose to name the program after her. Specifically, when I was struggling, I remember feeling like I was broken, like there was something wrong with me, and that I didn't know anybody else who was having these struggles. I think that brings a lot of shame and just adds to the feelings of hopelessness and loneliness and depression. When you have a baby, you expect it to go a certain way and it to feel a certain way, and when that doesn't happen, you can't help but wonder what you're doing wrong or what's wrong with you. I wanted to create a program that brought women together to share in their struggles, to help decrease that loneliness, and to help improve the feeling of hope that we are not alone and that we can help each other through these challenging times. I also find that imagery is an important tool, and that's where the lighthouse comes from. While some, I'm sure, find it kind of corny or dramatic, I think a name is important, and this one helps give an idea of what the purpose of this program is. A nautical lighthouse shines a bright light even during the darkest times and the most dangerous storms. Olivia's lighthouse is also meant to be a beacon of light for mothers, one that shines for all of its participants and in honor of my own daughter. So, a little overview of the program. I think the mission statement kind of sums it up a little bit more. Olivia's Lighthouse promotes awareness and provides support, counseling, and education around postpartum mental health struggles for all women and their loved ones. Taking a look at what the program focuses on and how we hope to help. So, in an ideal world and situation, I would love to have a comprehensive mental health program for women and their families during the perinatal period. This would include postpartum depression, but also anxiety, OCD, and even screening and treatment for postpartum psychosis. However, for the sake of this project and not wanting to bite off more than I can chew, I am focusing on postpartum depression. Although there will undoubtedly be some co-occurring diagnoses that come into play. A lot of us have an expectation of what it will be like to have a baby, and often our reality doesn't always match up to what we expected or imagined. When a woman has postpartum depression, it can be especially challenging because not only are we dealing with the symptoms of postpartum depression, but many also feel a level of shame because they don't feel as much connection to their baby as they see others having. This is a lonely and challenging headspace to be in, and I believe strongly that individual therapy is very important during this time, but I also think that group therapy can be tremendously helpful, bringing about a healing via the comfort of learning that you are not alone. And this is why the foundation of this program is group work, not only to educate and support the mothers, but to help educate and support the families and to advocate for treatment for anyone affected in my local community and beyond. The research shows that postpartum depression is a serious concern. 1 in 7 women that give birth experience postpartum depression, and this is distinguishable from the baby blues. So Being sad for a few days after delivering a baby is normal and expected, although sometimes more extreme than others. But not all women that experience this tearfulness in the first few weeks are diagnosed with postpartum depression. Postpartum depression does not go away after a week or two. It does not get better that fast. And so we need to make the distinguishing diagnosis, because we want to make sure we're getting the women with true postpartum depression the help and support that they need. Postpartum depression is also the leading cause of maternal suicide, and suicide attempts during this time period have a higher proportion of attempts using lethal means compared to those utilized outside of the postpartum period. The data in Wisconsin specifically, as of 2020, shows that 10.5% of new mothers are diagnosed with postpartum depression. This is actually lower than the U.S. average of 13.2. However, it is still higher than the prevalence of non-postpartum major depressive episodes in Wisconsin adults, which is at 7.5. And it is also higher than the percentage of serious mental illnesses in general of adults in Wisconsin, which is 4.88. And as I previously mentioned, I believe, as does the research show, that there is some effect on the children of depressed mothers, and this includes postpartum depression, of course, as it's such an important time in a child's development. Postpartum depression has been linked to developmental delays among infants of depressed mothers, including social interaction difficulties, attachment insecurities, and cognitive impairments. This just reinforces the importance of help and treatment and support for these women and their families, because it not only affects them, but it affects their children as well. Perinatal depression, which is a major depressive disorder occurring during pregnancy or within 1 year of delivery, has detrimental effects on birth outcomes, infant attachment, and child behavior development. Up to 1 in 6 women suffer from perinatal depression, and despite availability of effective evidence-based treatments and frequent contact with OB providers, less than 25% of perinatal women who screen positive for depression receive treatment. There is a need for access to treatment, and I think part of that is having a place that focuses on it, that providers can send their referrals, where they don't have to try and then find someone who can help with postpartum depression. This will be a place where they can call, and that's what we do. That's what the groups are for. There are some great community resources that help educate, advocate, and even help women find treatment for postpartum depression. Perhaps the most long-standing is the Postpartum Support International, or the PSI. It was founded in 1987 by Dr. James Alexander Hamilton and Jane Hunkeman. It initially included members from England, Canada, South Africa, Australia, and the United States. In 2005, PSI merged with a New Jersey organization called Depression After Delivery, and this helped create a larger and more diverse pool of resources, including a Wisconsin chapter. The PSI network is for U.S. providers. They also help to provide direct peer support to families. They train professionals, and they provide a bridge to connect them. The PSI has created a website anyone can visit if they're looking for support, education, or local resources. There is a support phone line where parents, family members, and providers can leave a message, and that is referred to as the PSI Warm Line. This service is offered in both English and Spanish, and within a few hours, a volunteer will return your call and provide information and resources in a way that offers non-judgmental support, which is super important. However, the PSI does not directly offer treatment or care for postpartum depression. It does, however, have a list based on your location of providers who are considered certified or validated by the PSI. Another local organization is known as the Periscope Project. This is actually run out of the Medical College of Wisconsin, and this actually deals more with pharmaceuticals, so not directly with counseling. However, I think it's a great organization to be aware of if working with postpartum depression, because it helps to train psychiatrists specifically in treating postpartum depression with pharmaceuticals, because that takes into account possibly continuing breastfeeding or which medications you can't continue to breastfeed while taking, and it just helps provide doctors with training necessary to appropriately help these women. Also, locally there is an organization called the Mom's Mental Health Initiative. Mom's Mental Health Initiative is a non-profit organization that is dedicated to helping moms navigate maternal mental health disorders by sharing information, connecting them to resources, and providing peer-driven support. This was founded in 2016, and it is located out of the Milwaukee area. The primary focus is peer-to-peer support. They have a website aimed to be a place that mothers can go to connect with other moms who have been through or are going through a similar struggle with postpartum mental illness. It is their hope that this commonality brings a better understanding of what each other is going through. And finally, the Hope line, which is a text support line, 741-741. Based out of the Center for Suicide Awareness. So this is not directly related to postpartum care, but to mental health in general. And it provides a unique way for people to reach out for help that doesn't even involve placing a call. I've had patients say things, like they just are too afraid to call, or they don't know what to say. So sometimes being able to text in this day and age is just a little bit easier for them. And it is a great resource to know about and to share with your clients so that they can use it whenever they may have a crisis or need support 24 hours a day. It is available. I'd now like to move on to the program design and how it is set up. First, let's take a look at interventions that I have used within program development. It includes cognitive behavioral therapy, dialectical behavioral therapy, mindfulness-based cognitive therapy, solution-focused brief therapy, and psychoeducation. So what does data show about these interventions, and why did I choose the ones I chose? So I think we're all pretty familiar with CBT. And the basis of it is that our patterns of thoughts and behaviors are connected. And it's important to understand that they are learned, which in turn means they can be unlearned. And certainly while we cannot wish away depression and or anxiety, we can learn better ways to cope with stressors, which will in turn hopefully improve our behaviors and quality of life. In women with postpartum depression, it has been shown that the addition of CBT reduces depressive symptoms more effectively than usual care alone, medication, and other therapies. Dialectical behavioral therapy, or DBT. A study done by Wilson and Donacci that looked at DBT as a possible treatment modality for postpartum mental health produced results that demonstrated a decrease in overall psychological stress and increased confidence in managing mental health and ability to cope with emotion. If you're not familiar with DBT, it was created by a woman named Marsha Linehan. She originally created it as a treatment for borderline personality disorder. It is often used also with highly suicidal individuals, and more recently has been shown to be effective with treatment of depression and anxiety and other mental illnesses as well. It is kind of a collection of skills that we can teach to our clients that help them manage aspects of their life. It is split up into 4 modules. The first is mindfulness, interpersonal effectiveness, emotion regulation, and distress tolerance. To ethically create a fully DBT-based program, it would be the most accepted practice for the counselor to be certified in this specialty. However, there are several individual skills and concepts that I feel can be taught within this group, and many groups for that matter, that can serve as tools for helping the clients manage stress and emotions. Moving on to outputs and outcomes. Ways to measure the outputs would be number of sessions completed in both the closed group, which would be the educational and therapeutic skills group, as well as the open group, and I'm going to go into those 2 group options in a little while in more detail. Some questions to ask would be, do the women desire to go through group sessions again? Were the number of established sessions enough for them, or do they wish to learn more or go back and revisit any of the topics? We can also look at the average number of sessions completed in the open process therapy group before women chose to discontinue treatment. How many women completed all 10 designed weekly sessions in the educational and therapeutic skills group? Did the program run as scheduled? Does the length of the program need to be reevaluated? Is there a need to lengthen or shorten sessions? Was staffing appropriate? Do clients and their loved ones feel that they have a better understanding of postpartum depression upon departure from the program? And do clients and their loved ones feel that they learned at least one new skill that has been helpful in their recovery? When it comes to outcomes, we hope to see a decrease in depressive symptoms, which includes decreased hopelessness, decreased agitation, increase in mood, or improvement in mood, I should say, ability to enjoy activities again, improvement in concentration, healthy relationships and connections to others, and anything else that was identified as needing improvement in the client's initial self-assessments, which I will go through in a little bit as well. We'll also look for things like sleep improvements. Again, this can be tricky during the postpartum period because there is expected but unrelated sleep challenges with a new baby, improvements in anxiety, and improvements in feeling bonded with their new baby. So taking a look at evaluations. So these are evaluations that I have designed for the program. The first is a self-evaluation. This is a collection of scaling questions. It's a quick and easy way to assess where they are when they start, and then we can assess these symptoms throughout, or at the very least at the end of program participation. I've also designed a group evaluation that I think is important because this helps me to understand and learn about what is working, what isn't working, what they wish there was more of, what maybe we focus too much on. It's just a great way to start to collect data about how the program is working for participants. There will also be assessments done during the group process. They will be done initially and then again throughout treatment. These are formal assessments that have been established that are used. Some will probably look familiar to you in mental health to assess for depression and anxiety symptoms. The first is the Edinburgh Postnatal Depression Scale. This is used to screen for and to evaluate PPD symptoms throughout treatment. And the GAD-7, which is used to screen for anxiety. It is not specifically intended for postpartum mental health screening. However, it is still applicable to general anxiety that can come with the postpartum period and or postpartum depression. This is what the proposed evaluation schedule will be for the group for Olivia's Lighthouse. So again, I mentioned there are two types of groups. There is the educational and therapeutic skills, which is a closed group, and a process group, which is an open group. So the educational and therapeutic skills group will have all 4 of the previously shown assessments and evaluations at this proposed schedule, beginning week 1 or at intake, and then staggered throughout so that no specific sessions they feel bombarded with assessments. I try to only give 1 or 2 at a time, and so that we don't take up too much of the group time. The process group will mostly use, at least the plan is to use, the self-evaluation and the group evaluation only, because this is meant to be a adjunct group to the other group for those that feel that they need the extra support. And again, I'm going to go into this in just a minute. All right, I want to now move on to program implementation. As I've been alluding to, Olivia's Lighthouse will consist of 2 types of groups. There will be a closed group and an open group. The closed group is an 8-week group consisting of 10 sessions. There will be 2 sessions each of the first 2 weeks, and then 1 session each of the following 6 weeks. This is meant to get off to a strong start, to really start providing support and treatment for these women, many of which have already been struggling for several weeks or months while waiting for diagnosis and or finding our program. These meetings will be more structured, and it will incorporate their support system. So we will talk about relationships, and we will talk about ways that their loved ones, their support system, can provide support in the throes of postpartum depression. There will be a week where they are invited to bring a member of their support system or 2. That can be a partner, a spouse, a parent, a sibling, a friend, whomever they feel like is there to help and support them. During that session, we will help the loved one to understand postpartum depression and to help them understand ways that they can provide support during these challenging times. A closed group, to be clear, means that, at least in this instant, that you can only begin in week 1 of the 8 weeks. Session 1 is when we accept new members. This kind of helps to build rapport in the group as we're talking through some of our biggest struggles, and it also keeps consistency with attendance and kind of a flow of the lessons. The open group is meant to be open to anyone at any time, so new mothers can join in any week. This group is open-ended. Each week is unique to itself. There will be 1 meeting per week, and this is more of a process group that's led by participants. And that means that, I'll open the session with any necessary business things, and then I will open the floor to people's questions or comments, and hopefully the conversation will flow naturally among the participants, although of course I will have a diary of prepared activities or topics in case the conversation naturally fizzles out a little bit. So this open group does not have structured sessions. There are not predefined topics, so we will not be going into more detail of that group. However, I would like to take a look at how our sessions for the closed group will be set up. So the initial session, there will be time, of course, to deal with business necessities such as consents, group expectations, introductions, and initial assessments. We will also introduce to the mothers what is our journal template. So this will be the homework assignment with the addition of a few other things throughout. but this one will be assigned every week. And the mothers are encouraged to either do it directly on this piece of paper or in any journal that they wish. But what we ask them to do at least 3 to 4 times a week is to document something they are grateful for, something they did well, and something that they would like to try differently next time. So I think that this encourages some positive thought, but also gives them a chance to record something that maybe they had an especially challenging time with, and then if they choose to, they can bring these concerns to the following session, which will be how we open session 2 and on will be open with discussion of challenging times, and it allows for feedback not only from me as the counselor, but also other mothers who may have great suggestions. We will also go into the difference between the baby blues, postpartum depression, and just, I guess, expected struggles of having a new baby. So I think this is really important because there are a lot of women who maybe have what is known as the baby blues. They feel a little extra sad. They're having some challenges that are a little bit more than the average woman experiences during the postpartum period. However, often these subside after a few weeks, and that is the huge difference, along with some severity of the symptoms, between baby blues and postpartum depression. After a few weeks, women with postpartum depression actually begin to feel worse. And just by looking at this handout, and this will be a handout that I give to the mothers, it's just really important. And it's not to minimize anybody's struggles with the baby blues, but it is to enforce the importance and the severity and the difference in true postpartum depression. We'll also briefly discuss warning signs of postpartum psychosis, which can unfortunately occur, especially if postpartum depression is left untreated. And we will go through the idea of a safety plan, and I will send this home with the mothers if we don't have time to finish it. But it's just while they're in a clear headspace, or to identify the ones who may not be in a clear headspace, but it's important to have the safety plan established while you're not in a crisis or an emergency mental health situation. Session 2. Again, we'll do the opening activities, we'll review the journal, then we'll do any kind of follow-up from session 1. Perhaps we didn't get to the safety plan, or perhaps there were more questions than we had time to answer about baby blues versus postpartum depression. So we'll go back to anything that needs to be followed up on or completed. I will provide the date for the Bring a Guest, which will occur during session 5. And then we will move on to a discussion about expectations versus reality, and how anyone can feel kind of disappointed when things don't go as you planned, whether that be during pregnancy, during birth, postpartum. Any of those things are applicable to our discussion, and we just talk about ways to kind of accept where we are and how we can then move forward. Session 3 again will begin with opening activities, and it will focus then largely on emotions. So I included here an emotion wheel. This is a really in-depth and sometimes overwhelming accumulation of emotions and feelings. And the point of this is to start helping them identify how they're feeling beyond good, I'm okay, I'm fine. We really want to start identifying truly how we're feeling in detail, because the more you become aware of it, the easier it is to communicate it, and the more effective we can be in helping to minimize the negative emotions. We'll talk about a skill called HALT. It stands for hungry, anxious, lonely, thirsty. And we will also talk about other skills such as TIP which is a DBT skill, which I will actually show in a little while when it comes back up, and just other ways to work on increasing positive emotions, decreasing negative emotions. Session 4, we will focus on what is called the wheel of support. So there are 4 components: instrumental support, emotional support, therapeutic support, informational support. All new mothers need support. Mothers with postpartum depression need a little bit extra support, and one of the most challenging things for some women is to ask for help. And so we're going to look at ways they can help themselves, ways they can provide opportunities for others to help, and ways that they can avoid help becoming harmful, such as over Googling things or scouring the internet to find worst case scenarios. This is the Wise Mind handout, so we're going to talk about that, how we want to be in wise mind versus our emotional mind, and how it's not even good to be living in our reasonable mind. We want to spend most of our time somewhere in the warm middle. This is also a DBT skill. And here's the tip we were talking about before. T stands for temperature, I stands for intense exercise, and P for paced breathing. So this is an acronym to help remember when we are feeling highly anxious. We want to dive into anxiety. What does it look like for you? How does it feel physically? How does it feel mentally? And then we're going to start developing an anxiety toolbox, which we will include that wise mind idea, the tip skill, the halt skill, and any breathing or exercises or meditation that the women find appealing for themselves. 8, session 8, we're going to talk about bonding with the baby and remembering to bond with any other children you may have as well. So we will look at activities that are age appropriate for mom and baby to do together, and part of the homework, as an example for this week, will be to try one of those things and then kind of report back on how it goes, how it felt for you, how the baby responded, things like that. Session 9, again, is blank. This will be, again, for anything that comes up that needs further research and further focus, and we will kind of tie up any loose ends before we head into our final session, which is session 10. And session 10 will be a goodbye. There will be a lot of time to do evaluations and assessments, and again, I guess finish tying up any loose ends. Really focus on how far we've come and the positive things that have happened in this process. And then we'll talk about next steps. There will be options for continuing on to the process group, perhaps couples counseling or individual counseling, and just kind of some things we can explore as a group, as well as the women will be provided options for things they may need to do on their own. Final thing I want to talk about today is budget and funding. So this program is meant to be run out of an established clinical practice. So for example, where I'm doing my internship, I am working to develop a back to school group for teens, and we will be charging a cash price of $35, or there will be like an upfront pay discount, get one session free or something. I'm not sure of the exact details yet, but this program will be run in a similar fashion. There will be a fee and a price based on cash versus insurance and whatnot. I do hope that one day we could provide some scholarships, or have more staff to do more groups, or even to have a brick and mortar one day. And then certainly, if that were the case, for any of those things, we would need some funding. So here are some funding examples that I shared a week or two ago on the discussion post, and they are mostly local, and then there are certainly many mental health agencies that provide federal and nationwide grants and funding as well. So that is all I have. I want to thank you for listening. Please leave any comments or questions for me. I'm going to scroll through references. And again, I really appreciate everybody listening, and good luck to you as we finish this class. And take care. Enjoy your summer. Bye.